Abigail, what's up, friend? How are you? Hey, Fanny, what's up? What's up, AJ? How are you? Welcome in. Welcome in. Hey, Christopher, how are you? Welcome in. What's up, Big B? How are you? How are you? I may or may not have live notifications. Oh, okay. All right. I'm happy to hear it. I'm really happy to hear it. I'm glad to have you hanging out. I think I did a live like day before yesterday. You were in the live for a little while, I think, like towards the end, I want to say. It was nice to do a live again. And I feel like everybody, like a lot of the core people who like would come to lives were in. And it was nice to just like kind of visit with everybody. Man of War, what's up? What's up? Vicky, how are you? Yes, I thought so. Abigail has entered the room. Hey, Aaron, what's up? Hurley, what's up? How are you? Kristen, how are you? What's up? What's up? I'm going to give it a few minutes for our friend Handoff to join the chat. We have some really incredible stuff to talk about. I'm so excited. I'm so stinking excited. Let's see. What's up, friend? How are you? Cardiology is going to be the death of me in medic class. No, Matt, don't say it like that. It is hard. Like I'm not even gonna lie. What's CARE Act? Okay, so the CARE Act of 2025 is basically the bill that's coming in to replace Bill HR 8977. For those of you who don't remember, last year I covered it pretty extensively towards the end of December. So basically, because of all the legislative changes and people being voted into office, the bill had passed the House. I believe it passed the Senate. That was basically a bill for community care paramedicine to help get reimbursement through Medicare. And this Bill HR 2538, I believe, is the one that's basically like the upgrade to it. It is the Bill HR 8977 walked, so HR 2538 could run. Oh, there's Handoff. He's in here. I'm going to invite him into the chat. SJ, what's up, friend? How are you? I'm glad you could make it. I'm so glad you could make it. We have so much to get into today.
What's up, Bossy?
How are you?
Man, it seems like it's been forever since we talked to legislation, but here we are.
I'm excited. I'm so excited. I was reading through the bill and like someone just asked what the bill was just now. So I was trying to give them a brief overview before we got started. Give a few more people some chance to come into the live before we start explaining what everything is. But how have things been on your end?
The last couple of weeks have been crazy. We've been in the middle of advocacy. So I've had the opportunity to be in my state at the state leadership conference for HOSA, and then went to DC for Day on the Hill. Got to talk this specific bill for a day on the Hill, a couple days within ourselves, and then getting to go to the Capitol. And then last week I got to go to Indianapolis and speak at FDIC.
That's what's up.
So,
Did you get to have any like direct influence over this bill?
So we have been on the national organization side. We have been pushing treat in place for a while now. So we have been trying to directly interact, and so our external affairs directly with Washington D.C. through the NAMT, who's going to be watching this as well. So obvious shout out to those people. They've got the day to day, basically getting this thing pushed forward. So.
That's awesome. That's so awesome. Okay. So for those in the chat who don't know, I'm just going to kind of briefly recap, talk about what it is exactly we're talking about today. So last year, Bill HR 8977 was basically a bill that was coming in to help cement the treat in place model and cement funding for treat in place, basically, so we could get reimbursed through Medicare. It got passed through the House, and I believe it got passed through the Senate as well at that time. Oh, thank you, Thad. But because of legislative changes and elections, that kind of had to start all over again, basically, because it didn't have enough support and it didn't have enough time to go all the way through. Now, Bill HR 2538 is being introduced, and it's basically, from what I can tell, Bill HR 2538. No, HR 8977 walked so 2538 could run. Like it seems like there's a bunch of good upgrades in the language and specificity in this new bill. So why don't you talk a little bit about that if you want to?
Yeah. So one of the key things I think everybody needs to know about where we were with the last bill and where we are now. So the way the Congress works in the 118th Congress, which is what ended at the end of last year, which is where 8977 was, if a bill doesn't get through all of the hurdles before the end of that Congress, it dies. And goes away. It has to be done, and then if not, it has to get reintroduced. So that bill, 8977, was introduced very late, and therefore there was a lot of push, a lot of energy expended to try to get it in that lame duck session. And that lame duck session meaning at the very end, and a lot, this is actually one of the biggest freshman class of representatives and senators that we have had in a very long time. So trying to get those experienced people to push this through, it didn't happen. So it has to be reintroduced. So the good thing is that Congress lasts for 2 years. We're in the very first quarter of that still. And so now we have 2 years to make this come into place. And so that's really where we stand. The fact that we've got sponsors for it on the House side, we're still waiting for this Senate sponsor side to come through because we do have to have companion bills on both sides. They have to match before going to the president. So the fact that we have so much time is a great thing, but it also reasons for things like this to occur is to ensure that we are pushing that and not trying to take the entire 2 years for that to occur. So that's where we're sitting at, a little bit of background where this new piece of legislation is. So as you and I talked last year, as we were trying to influence and push and advocate for this bill to go through, this is probably the single largest shift in EMS since going back to the white paper that created modern medicine on the pre-hospital side. We go back to the starting days where we realized that we needed to take people to medicine. Then in the 60s, we actually said that we need to push the medicine forward. And now we're saying we're giving our highly educated practitioners, EMTs, advanced EMTs, and paramedics, the opportunity to practice medicine and not lose out on money. Here's the key thing. If we are not picking up somebody and taking them to an admitting hospital, a destination hospital, the EMS agency doesn't get paid. This allows our people the opportunity to use medicine, practice medicine where they are, take them to the hospital if needed, or treat them, release them, and get funding to support some of that. So one of the biggest examples we use is the diabetic patient. Everybody knows these patients. They're hypoglycemic. Chances are we know their name, we know where their peanut butter is, and we know where the orange juice is. We know it. We start their IV, give them some D50, D25, give them some orange juice. They're fine. We get no money from that.
Right.
And this would allow us the opportunity to recoup some of those costs. And as we're going to talk about here in the next little bit, there's so many different things that come about because of that. We'll talk about overcrowding. We're going to talk about unit-hour utilization of the ambulances and stuff. But we put some money back in the system, which is going to allow us to buy new equipment, allow us to upgrade our ambulances, and allow us to potentially pay our individuals, our practitioners, even more as well. So
the biggest thing that I loved seeing in this bill was that Medicaid was also on the bill. Like before, it was just Medicare. I think that's fantastic. They added Medicaid to the bill. Do you know what brought that on? Why it was left off in the earlier bill, but now is on this bill?
Well, so one of the things when you're looking again, when we introduced it previously, we were at the very end of the session. And so the more aspects that you add to it, the longer that it takes to get through, because you have to look at all the actuarial studies, the fiscal notes that are associated with that. And so the more that you put towards that, the longer it's going to take to go through. And the fact that was at the end of the Congress, 118th Congress, we needed to get it passed. And so now we have the opportunity to actually take a look at where it is. And when you take a look of ambulance utilizers across the country, Medicare and Medicaid are the two biggest areas that are utilized. Now, the one thing that's not specifically addressed, because we can't, is the private insurers, which will actually turn around and see this because they use Medicare and Medicaid as their kind of their blueprint and whatever they're doing, they use it for reimbursement rates, and it will help with the privates as well. So we're going to see a lot of expansion for EMS through Treat in Place.
Yeah, no, that's going to be awesome. Now, I also wanted to talk about, like we had talked about it earlier in DM, that there was something specific in the language, and maybe I misunderstood it to a degree. But what I understood the language to mean was that the Department of Hospital and Human Services, one of the other big things is that they really can't push us to the side because of the specific language in there, that we're basically a priority. It's not a matter of if we get it done, it's a matter of getting it done, because there's a 2-year limitation on like it being implemented into place. Can you kind of give us a bit more insight on that?
Yeah, so you got to kind of look at and see where Medicare, CMS is housed, and you got it under HHS. And so this, by putting it into legislation, takes us kind of off of a back burner and automatically puts us on broil, right? So it changes that spotlight, puts the spotlight directly there and says, you will do this. And, as you take a look at a lot of things, you look at shall statements or must statements like, well, you shall do that. Well, that sounds great, but you must do that. And we're in the must area now, which means this is something that has to be done. And there's a deadline or sunset put in there so that they can come back and take a look and say, okay, this is being done, this is not being done, and they can make those adjustments at that point in time as well. So by doing this, it forces that prioritization. We're not at the level of saying EMS is an essential service in everywhere, which is something that we definitely want to see. But it does put that spotlight to say this is funding. They are a priority. And because you take a look at that, why is this such a priority? Well, by us treating in place, we actually save the healthcare system a tremendous amount of money.
We all been saying that for years,
And HHS has got to now see that as like now instead of a $10,000 or a $2,500 ambulance transport and a $10,000 hospital stay, we're looking at $500 to $1,000, small amounts of money in comparison to the whole thing, and say we're gonna handle this and take care of this way. So yeah.
I think the thing that is most exciting to me, and again, please correct me if I'm misunderstanding this, but the specific language it's being used has not for must EMS and HHS, the Department of Health and Human Services, that combination has not really happened prior, and it sets a good precedent for us basically later on down the line if we want to make a case for becoming an essential service.
Right. So previously, if you want to, as I've been kind of using the spotlight metaphor, we've been in the outside of the spotlight. There's been light shined on us, but it's not the primary beam. And now that beam is being shifted over to us. So HHS has looked at us as being there, but now we're directly in the spotlight. And so that's going to bring a lot of attention going forward. And it's kind of like COVID. COVID kind of put the spotlight on EMS as well. And that's where we started looking at a lot of different changes in our actions, leaving just the healthcare and going into public health. I know we've got some conversation about MIH as we go forward as well, but now we're looking at that shift and saying now that spotlight is there, and so we're going to see a lot of stuff come to us because of that.
Yeah, that's so exciting. It's a historic time to be around.
Now, the one thing I'll say is it's historic, and the second part of that, and the reason you and I are doing this right now, and so many others that are out there, is it takes every single one of us. I'm going to use an example real quick off of this topic, but Medicare extenders, which is something else I've talked about, was set to expire with the continuing resolution on the 31st of March, which would have bankrupted a lot of agencies if it failed. A large campaign through NAEMT's online legislative service, AAA, and some of our other national organizations got people to come together, send messages. And if it wasn't for 4,000 messages through NAEMT's online legislative service, wasn't through AAA, through grassroots organizations like yourself, me, and some of our different individuals out there calling their congressmen and their senators, writing a letter, sending an email, those would have failed. That was rolled into the CR that got extended. These services continue to pay while reimbursements are there. So it's historic, but it's going to take each and every one of us, the millions of licensed providers across this country, to continue this, to say, hey, this is something that we need every one of us to do, because there's two things that move legislation. That's money and that's people. And I will tell you, people come more important than money does. You all show up in their inboxes and on their voicemail messages, on their front doorsteps of their local offices, or going to DC. All of a sudden, we're going to see this shift and actually make this happen.
Yeah, that's so awesome. Now, I also wanted to talk about how the telehealth had also been specified in the language that they use, and like the specificity of also like a scene being designated as a place that's could potentially be billed from. Why was that put in the bill, you think?
Well, so telehealth, telehealth is something that is rapidly expanding, and I would tell you the capabilities are absolutely there. Now, one of the things that you and I have talked about is, and I know we're going to talk about is should we be the final definitive guide? As we get into that, what I'm going to say is there's going to be specific things that maybe we're not, but as I take a look at this, telehealth is out there in such a way that it can amplify what our providers are already doing. I'm going to use an example of my own family member. My mother went through a situation, and she ended up seeing a telehealth doc for neurology because of her situation. They did a thorough assessment there, coupled with what they got from the hospital staff, and they were able to do some diagnosis on her to find out what's going on and then follow on. Absolutely loved it, and it was almost better than the regional academic institution that she was seen at just a month before. And so we can press that forward. So does telehealth only have to be done in the hospital? The answer is no. We have those capabilities. You and I right now are from two different states, two different time zones, and we're having this conversation with a large amount of people that are on here from our states and around the country, right? Things that we can do is phenomenal. So if we can couple those scenes that may be a little bit above what we are able to make the decision on, bring them in, let them consult, and say, hey, you're good. I'm going to do this, this, and this. We're going to call in this. You're done. Or you do need to come into the hospital. We need to do some more diagnostics because we just don't have it in the field yet.
Right.
So,
right.
So and again, it's one of those that, because now we have a little bit more time than we did at the end of last year, let's toss it in there, make it an option. It's not making it mandatory for everybody to do telehealth, but it's making it an option for those that are able to do it.
Right. Now, what kind of state laws do you think or bills would complement this new bill that's coming in?
So, one of the things that we were talking about kind of setting up here is talking about telehealth. There's a lot that don't have anything when it comes to EMS and telehealth. So once that doc comes involved, are they now in charge? If they relinquish care back to us, is there an issue with abandonment? Who signs off and how do they sign off? The state of Tennessee is actually taking a look at that right now. From our state regulatory board, we actually have two subcommittees, or two committees, our ambulance committee and clinical issues, which is headed by our state medical director, that have work groups underneath them that are looking at telehealth. And so what rules need to be put into place? Because there's a couple things like privacy, right? I take my iPad out there and I just use FaceTime. What end-to-end encryption does it have on there? Is it safe? Is it secure? Those kind of things. So I think there's some cybersecurity things that will need to be addressed. It also just needs to see if the rules that govern your EMS agency's policy does it allow telehealth to occur. Ours doesn't promote it, but it also doesn't inhibit it because there are no rules for it. And so, our Office of General Counsel said, y'all probably want to discuss this because it's such a big prime mover. Now, treat in place, we'll have to take a look at rules as well for the state to say, what an EMS agency does, because we have been defined since the 60s as pick them up from the insult or injury, wherever that is, and take them to an admitting hospital. And now we're going to have to look at that and see if there's anything that needs to change. Hey, what does it mean to definitively turn somebody, terminate the call without ever transporting and show it as complete? So those will have to be reviewed. Now, because every state is at a different point, it's going to be where that state is to determine how those changes need to be made. Now, what I will say is, because state rules do take a little bit of time to change, they need to be looking at this now and looking at what changes needs to be implemented to allow it to happen as soon as this goes into play.
Right, right. So how do you think if the bill does pass, how do you think it will overall, what will be the opinion of most other EMS professionals on this bill? Do you think it'll be widely accepted or widely criticized?
So the one thing is this is not the way we've always done it, right? And then there's going to be a lot that said, hey, it's just easier for me to take them there because we're looking at passing off that legal liability. I'm going to take them to the hospital. I don't have to worry about it because the doc's going to sign off on whatever they do. Guys, it's not the way it is. We are highly educated practitioners, and we've got to buy into this. There's a lot that can be done.
Like it.
Yeah, right. Let's absolutely. It's like let's do what we need to do to make this happen. We know that healing at the house, typically there's some bad home situations, but typically healing at a place that we're comfortable, we're going to heal faster, we're going to heal more completely. So staying in an emergency department, my mom, again, I go back to her, she would, if she had TikTok and heard this, she would hate that I'm talking about it, but she was admitted to a hospital, a regional academic medical center, for 60 hours, and she was in the emergency department the entire time. They didn't have spot for her on the floor. So there was no quiet. There was no calm. They came in every hour to round because she was in the ED and they had to follow. Like, there was no recovery. And so that's something that we have to do. So if we can do that at home. So as practitioners, we've got to say, hey, we've got to buck up, be the practitioner that we are, go out there and do the job. So like I said, there's going to be some, it's not the same as we've always done it. Great.
Right.
Let's then take our knowledge and our skills and go out and do the job. And, it's going to enhance our profession because we're going to be bringing in the money that we should have been. A lot of this goes back to money. We're going to be bringing that money in that we should. But overall, it's one of those that our patients have got a better encounter. They are responsible for less money. They're getting better care, and we're helping our profession grow at the same time.
I agree. I actually had that question or that's been the pushback that I got when we were talking about HR 8977 and one of the many posts that I did about it. And I don't know, I'm sure there is definitely some type of, legal back and forth, but in my opinion, just looking at it straightforward, if you do a good assessment, you shouldn't miss that. There should be more time, but it shouldn't really be more risk if you do a good quality assessment to begin with.
So if you don't follow Doug Wolfberg from Page Wolfberg and Worth, he has been talking a lot about legal liability and what we know about it. And he will flat out tell you we are wrong. And because we have perpetuated these stories from amongst each other, that not necessarily the case. Right? If you are absolutely out there doing what you can to the best of your ability, it's not that you're not going to get sued. And that's the key, because we can sue everybody for everything. Take a look at the lawsuits that are out there, right? Everybody can be sued for everything. But if we do the right things for the right reasons, chances are we don't have any problems. You take a look at some of these cases that have been out there, and I'm not going to go into any specific ones, but the high-profile ones where we have practitioners now going to jail in various states, there's an intentionality to their bad decisions, which really come into play. If we're doing the right things for the right reasons, then it's very hard to secure a charge against you. Yeah. And so that's what we're looking at doing. Like, we want you to go out there and do the right thing. we arm you with a lot of information in school. You get a lot of follow on by all the care that you do. Like, put that to use out there. Do it for the right reasons. Look at how many people we NPC or patient refused AMA or whatever because we didn't. You're not really, but you don't want to go to the hospital. They're too busy or whatever. Just sign here.
Yeah.
You know, and it's like we're doing it already. By doing this, we do the right thing, bring in some money, and so you make a better environment for it.
Absolutely. No, I agree. And that's the other thing too that I think people aren't considering is that we're not telling the patient they have to do this. We're giving them the option. It's still like you still have to have patient consent to move forward. That's the other layer,
Right.
Is that it's all based upon informed consent.
Right. And that's the thing. If they say, no, I need to go to the hospital, because the other part that we haven't talked about all this, there's a huge patient education or community-based education that we have to do, because everybody expects you call 911, get the ambulance, go to the hospital. And the first time we say, hey, this is all you need, sign here, I'm supposed to go to the hospital. So there's a whole lot that we have to do there.
No, absolutely. There was, because we did the ET3 during the panorama, and there's a lot of patients that I considered, good candidates for treat in place, call a doctor, telehealth. And one of the obstacles was getting them to buy into it in the first place. And we offered it to them. That's all we did was we offered it as an option, I think. And I would always tell the patients, like, based upon your symptoms, your medical history and everything going on today, it could be X, Y, and Z thing. But because I see this, not this, I'm really thinking that today you just have the flu or whatever.
Yeah.
And, if you want to go in the ER and wait, you can. Or I can talk to a doctor. We can try to get the prescriptions for you and sell it. And even selling it to them like that, like in what I consider to be like a very reasonable manner, and taking the time to, a lot of them still didn't really want to buy into it because they had never heard of it before. And we had patients who eventually, like after a couple of times of seeing them, they were frequent flyers. Like, I really don't feel like going to the hospital today. Let's go ahead and give that a try. And that it was successful some of those times, but I agree 1,000. It's almost like we have to market it to them in the correct way.
And that's it. It's a huge public ed campaign. In the fireside, we'd be calling it community risk reduction. We'd be educating through the media, through mailers. We'd be going to communities. We'd be doing community events. There's a huge aspect to that. But hey, guys, this is the right thing. You don't need to be in the hospital for this. It's going to cost you $15,000 to be there. It's going to cost you $580 for us to take care of you, and you get to heal at home, and you have access to this stuff. So,
right. No, I couldn't agree more. I think that, and I think part of it is just going to be time and introduction, and I think just presenting it in the right way. Like at my service too, we also have somebody's like a community advocate, and anytime we have frequent flyers or like they need additional resources, like it's a neglect type situation for like the elderly, this person will go out and do community stuff. And, further expanding upon that role, I think would be a great place to start introducing this. If there is a role at, anybody listening to EMS agency, that'd be a great place for them to kind of start putting out soft feelers and flyers and speaking to them about the program.
And let's expand this conversation a little bit more, because we've kind of danced around the topic. So Treat in Place is the 911 version of mobile integrated healthcare. So there's actually another bill that we're working on to try to get in place to expand MIHCP. And MIHCP is basically the non-emergent version, where this is talking about 911. So somebody has picked up and called 911 and done this. Now, we see some of these things that take into place because this individual may not be a candidate for home health, or not candidate to, we know that they're not going to follow up with their PCP, then we can turn it over to our MIH departments, or MIH side of our department to say, hey, Bossy is here. We had this 911 call. We did a treat in place. This is what happened. We don't think they're going to be compliant with PCP. We don't think they're going to follow on with anything else because they don't qualify. We're going to turn it over to our MIH side, who's going to come in and follow on. Hey, Bossy, we know that you called 911 about 48 hours ago, and it's a good time because we thought you were going to follow up with your PCP. Can we come by and check you out? And then they can follow on. And so that second bill, hopefully we'll be doing this again shortly to talk about MIHCP, because that's the next iteration, so that we can be kind of that holistic provider from pre to post. We're not looking to take anything from home health or from nursing. We would just make sure to treat them at the right place at the right time, which decreases our demand, believe it or not. When we do
Not
this,
just that, but like with the skills that we have specifically in pre-hospital care too. I think that's more of what we do differently than a lot of the other disciplines, is that we specialize in pre-hospital care. That's our whole training from start to finish.
agreed. Absolutely.
Yeah. So let's see what else I had for you on here. I have other questions. Do you think that there could be any negative outcomes from community paramedicine outside of like what we've talked about, maybe legal stuff like that?
So the answer is yes. Anybody that tells you no is going to be absolutely wrong. Take a look at the hospitals, right? They have a ton of people, a lot of education, a lot of resources, and they get things wrong too, right? Absolutely. We go out into the field where we may not have everything that they do. We don't have CT. We don't have MRI. We're starting to see things like ultrasound become common practice in some of those areas. So we're enhancing a lot of our point of care testing, but we don't have a lot of the other stuff yet. So is something going to be missed? Absolutely, right? We get some indicators of a preseptic type patient, but they don't really meet that. Hey, follow on, may need some antibiotics or something like that. And we don't know that they're one step away from walking off the edge. It happens, right? Which is why we're going to have to educate our people to do as much as we can. I have always said err on the side of caution, take them to the hospital, but use as many of our indicators to get them there when they need. So yes, things are going to happen. Now, if you ever hear me talk about some of the stuff, I could sue you for anything. I've already said it once today. I use an example about a stroke. You don't show up you take them to the right hospital, I'm going to sue you. You take them to the wrong hospital, I'm going to sue you. Like, it's going to happen. And we have to educate ourselves in the courts on how to present in the courts as well, because that's where a lot of us have issues. We don't want to be there. We get nervous. We educate ourselves into what we're supposed to do and what we do in the hospital or in the courtroom. And hey, we take that on. We know it's a situation. Hospitals do it all the time. They've got people to do that. We'll have to do the same.
Right. Yeah, I think we could think about safeguards too for that, like just a follow-up call. Hey, you can expect a follow-up call from me for like an extension of dispatch in an hour. Okay, they're not answering. Maybe we need another unit out there to check on them, make sure they're whatever. I feel like there's also safeguards that we can put in place to mitigate that.
And that's absolutely correct. We're going to have to start looking at our patients holistically. How many times have you been to the doctor or to the hospital and they call you 48 hours later? Hey, Bossy, how are you doing? Why are you calling me? Well, we wanted to make sure you're not dead at home. Really, if they were to be honest with you, we just want to make sure you understand the meds and all that. No, they want to make sure you're not dead at home because they let you go at 23 hours because the insurance wasn't going to pay for that 1 day admission, right? So they're doing it. Why aren't we? Now, we have commonly operated very lean because we don't have all of the reimbursement we need to put tons of people. Well, now we're focusing on bringing money in. We're going to expand this, like you said, make a phone call, make a trip by and just say, hey, again, this is our push for MIH to say our MIH paramedics going to go out. Hey, I just wanted to make sure, Bossy, that you're good with the meds that the docs called in. Have you picked those up? Were you able to pick those up? Do we need to get you some social assistance out there, Meals on Wheels, those kind of things, and bring those resources along? So, yeah, is it a phone call? Is it a visit? Is it a follow-on with the pharmacy? There's a few things that we can do to say, yeah, this is, and as a practitioner that saw that patient, I'm like, hey, this is a high acuity call that we probably need to follow up in the next 8 to 12 hours, or lower acuity call, 48 hours, you're good to go.
Right. Yeah. I think that's a great way of using the provider's impression to steer that.
Yep.
Let's see. So what do you think needs to happen for protocols specifically for like the just the kind of the meat and potatoes of what the core things that you need to have in terms of protocols for treat in place?
So I think this is very generic. We could go down a rabbit hole and create a protocol manual that's 10 times as large. We're never going to be able to document everything that is possibly going to happen. I mean, we all know that, just a heart attack, a heart attack with a blockage in a very similar area is going to have two different responses in the body. You're not going to ever have anything that's perfect. So it's like educate and give you kind of what that scale is to say, hey, you really need to take this person to the hospital, or they can just stay at home, or telehealth this appointment. So how do you incorporate all of that to make the right decision? I think it's more of a decision-making tree. And I personally think it's more of a continuing education issue versus protocols. Like, how do we utilize critical thinking to the best of our ability?
Yeah.
And the protocols just kind of give us the guidelines. Hey, if you're pegged all the way out of here, go ahead and take them to the hospital. If you're here in the middle, let's look at telehealth. If you're over here, discharge with the follow-up to PCP or to MIHCP.
Yeah. So Archie here has a pretty good question, and I'm kind of, as he's saying it, I'm thinking of a question in my own head. Do you think that the implementation of a paramedic practitioner would be complementary to this new bill that we're coming in, the HR 2538?
So there's a lot to that, because there's a lot of conversations out there already. Do we want to create a graduate level paramedic practitioner? As an educator, I advocate for education. I have a technical certificate. I have comments about degrees, and we can talk about paramedic practitioner, or we can look at merging with some of the things that we currently have. So a good friend of mine is the director at Austin Travis County. They have PAs and NPs that are on chase vehicles that are working full-time employees for Austin Travis County that are coupled with the medic. So they're like, hey, I need doc. And so you get your PA or your NP to come out there and follow on with you as well. Now, as a true EMS, fire and EMS person, that's where I've spent the majority of my career. I would love to see us advance to have graduate level prepared individuals. I don't know that we have the right answer to what that looks like today. Because we say we want to be PA or NP, or we want to be a pre-doc kind of individual. But we need to be us. PAs operate in the hospital or in doc offices. NPs are the same. Doctors obviously are working in those environments. We are not. And so if we're going to do this, let's start with a room with white walls, and they're blank, nothing that we currently have, and let's design the system that works, the funding for it, like put everything together. Some of these I think are great starting blocks for a lot of those conversations. I think the conversations do need to occur. You posted a lot on degrees and out there. And the key thing is you listen to input. I listen to input. You put two of us together like we're doing this right now, and I think you're going to get a lot of additional good conversation. Don't just dismiss it because it's not what I like. Let's conversate. Let's figure out. There's three truths to your truth, my truth, and what's actually in the middle. And the closer we get to what's in the middle, what's best for our patients is what's going to be best for all of us.
Agree. So I have a few comments, Dave, if you want to reintroduce yourself, and a few new people in the chat now, if you just want to briefly tell them about the bill that we're talking about right now.
All right, so I'm David. I'm handoff medic here on TikTok, so you can find me there. I get to serve in a couple of different capacities. One of my ones is dealing with the advocacy side with the National Association of EMTs. I'm a board member within AEMT and covering Tennessee, Georgia, and South Carolina. So I'm in tune to those three states, state legislature, as well as the federal legislature as well. And currently talking about treat in place, and I apologize. You've got the bill number in front of you. I didn't get prepared with that. I sent it to you, 2538, right?
2538.
Yeah. HRES 2538. So we are waiting on the Senate companion bill for that, but been pushing this side, looking for co-sponsors to get on there. And that, so HRES 2538 is what you can find if you go to the the house side, and again looking at that companion. So
Yeah. So my next question is, do you think it would be better if the framework for treat in place was delegated to each state, or if there was a national standard for treat in place?
So with the way our country is founded, and I'm big that we've got a lot of states' rights. Let the states dictate that, because you're going to have something different every state. Having a good federal framework is not a bad thing. And when we get to the side of talking about essential services, we've got about 23 states. I think it's 23 now, maybe a little bit less. I apologize. That are considered essential services, which means that we have everybody expects EMS is an expected service, but essential means that there is somebody that is providing that. So as we get there, having that federal framework to put together that we should be there, and by looking at some of this stuff like the treat in place legislation, having that framework out there that passes that along, and just making sure there's. Here's one of the things: when you have the multiple local, state, and federal laws that are affecting this, you got to make sure all of them operate. So if one of them is off, then somebody's going to get in trouble. That's where we get into bigger legal liability. So having a good framework at the top that allows it to happen if the states want, we follow on and create the authorizing legislation at the state level, and then each of our municipalities, however it's broken up, parishes, counties, etc., can have this final authorizing. Hey, a good friend of mine is down there in your area. The state director, Susan Bailey's doing some good stuff down there for you all. But I've learned a lot about parishes here in the last 2 years working with her as well.
Got to be different. Got to be different.
Yeah. It's the only one that's still operating what is it? The Napoleonic Code of France, I think is. Yeah, it's kind of.
There's a very heavy French influence still to this day in Louisiana, and it's beautiful. It's part of our culture, but
But when here's the key thing is when you're advocating for this stuff, like you have to know that. So if I was to walk into Louisiana last year, I helped advocate for Alabama. Like you got to kind of know that area. So when you walk into those offices, I'll use an example here in the state legislature. I walked into a office of a representative that covered Murray County, Tennessee. Well, in my area, which is on the east side, she was in central or middle Tennessee, we have Maury spelled the same way, and there's a school and others. And so I was going in calling it Maury County, and she's like, if you don't pronounce it right, you're getting kicked out of my office. And I kind of chuckled, and she said, I'm being serious.
Yeah.
And I stopped and I said, do me a favor, pronounce it one more time, because that's how it's pronounced over here. And that's because it was named after the family, the Murray family over there. That's how it's pronounced. That's how they said it. And they're so you got to know that kind of stuff. You walk into an office in Louisiana and I say, hey, your counties, and we don't have counties down here.
Yeah.
And
yeah.
You get kicked out. So
yeah, every time we're on the news for hurricanes, when they try to pronounce like the name of our parishes, Atchafalaya, Ponchatoula, all that, we just laugh because there's no getting it right.
Nope.
Yeah.
Nope.
Yeah. Oh man. Okay. So what kind of patients do you think will benefit most from this program?
So the two most common ones that have been talked about right now are going to be your diabetic emergency patients and your overdoses. Those are the ones that we're seeing right now. Those are the ones that we're commonly treating and releasing, because after we give them the treatment, they meet the requirements for being released if they say we can't treat you. So that will allow us. Now, if you take a look at the statistics, we'll have more of a chance for reimbursement on the diabetic side, the hypoglycemic side, because we do know that a lot of the overdose patients are not typically payers into the system. And, so we're going to see a lot of the diabetic patients. Those kind of calls, and we got some anaphylaxis that we can do, we'll need to follow on. The one thing people need to know about this is it's not going to be a quick thing. Like I just walk in, give a treatment, and walk out. You're going to be spending a little bit of time, but ultimately it's less than going to the hospital. Those that we're still concerned about chest pain, stroke, undiagnosed seizure activity, we're still be taking those to the hospital.
Right. Yeah.
It's those that we have those medications for, nausea and vomiting. And I saw it in comments. I apologize, I didn't catch who it was, but they're like nausea and vomiting patients. We can administer some kind of antiemetic, give them a bag of fluids, and chances are they're good to go, right?
Yeah. Yeah. No, that was my most common customer during ET3 was I have a stomach virus. Give me some Zofran, give me some fluids, give me a prescription so I can keep it all down. Let me write it out.
Just anybody that's up in East Tennessee treating me, don't give me Reglan. That's all I ask. I cannot. I have a sensitivity to it, and it's not a good environment for any of us.
No. Let's see. Okay, so I think this is my last question. Do you think that like smaller EMS agencies, do you think this will help them or harm them more in terms of just like risk and implementing kind of this new infrastructure?
Help 100%. So, when you take a look at those rural EMS communities, most of those are hospital deserts as well. They're transporting 45 minutes, an hour, hour and a half, 2 hours to get to a hospital. And every time one of those ambulances goes out of town, their community is unprotected. So by risk, we are able to see more patients. We can see them quicker. We can get them care delivered to their house without them having to go a long way. There's a lot of benefit that's going to be. There's going to be some infrastructure upgrades if they implement the telehealth side that we've got to take a look at. And there's obviously, hopefully, going to be some money that comes behind with some grants to help with some of that to make sure the infrastructure is in place. But to be honest with you, I will tell you that a lot of our rural agencies that are having to transport an hour and a half to 2 hours, these guys are fantastic practitioners because they have a lot of time with their patients. They do good work, and we're just going to allow them to do the work on multiple patients in their community without having to go out of town 3, 4, 5 times out a day. Because if you take a look, if they're doing a 2-hour transport out, that's 4 hours round trip. And that's already a seventh of their overall rotation that they're out of the community, and for one patient. And in that 4 hours, they can see 3 or 4 patients and have a humongous impact.
Now, I do remember I have one more question for you, because this is something we talked about last go round. I want to see if your opinion on it has changed or not. We talked about, do you think that all EMS should be equipped to be a community care paramedicine, or like should there be certain ambulances that are designated for emergencies and then certain ambulances or like go trucks that are specialized in like the longer term, or tasks, or better equipped to deal with the longer times and care that comes with doing a treat in place patient?
So I think seeing EMS as the white box with orange stripe those days are gone. We're going to have to take a look at multiple different modalities to make sure that we're getting the right people to the right patients at the right time. So I'm really big about being in a white room and just putting what is good for your community up there, working through a mind map to say this is what it is. So I personally think, especially once you get to the larger communities, it's definitely a combination of transport units with quick response vehicles and those that are stocked and staffed to do long-term, like you said, the MIHCP side. So there's multiple aspects that we need to look at to make this actually a reality. So yes, I firmly believe, again, and I know a lot of people have got away from the white ambulance with the orange stripe, but that's what we most commonly think. Like we think EMS is the white ambulance with the orange stripe, and we really need to take a look at the system as a whole. When we get into this, if we can leave this with a single practitioner to do that, bring the transport back to another side, and have them focused on getting the right patients to the right place, I think is going to be key. I take a look at the airline industry. They operate a lot leaner than we, because their margins are as small as we are. But, making sure you've got the right resources, moving people, moving places, and that's where a lot of data collection is going to have to come in. Do we have our stations in the right place? Do we have our equipment in the right place? Are we responding to patients the right way? And because along with all of this, do we need lights and sirens all the time? Like, a lot of these questions need to be asked as we're making these large, treat in place, MIHCP. We've got a lot of good things that are happening right now. Use this to say everything can go if it's not working for us. Build the data plan, build your Con Ed, build everything around making sure your service is offering everything in the best way possible.
Yeah.
I do want to go back, if you don't mind. There was a question. I'm going to probably say wrong, but Kenesha is on here. Would these also count for private ambulance services or just county, community, state-owned? And the way this is set up, it's all billable. Anybody that has the ability to bill through CMS for Medicare and Medicaid services. I wanted to specifically bring that out to say there's a lot of bills that exclude privates, but in this, it's if you're doing any kind of emergency care, it would cover all of those.
Yeah. Were there any other questions that you wanted to answer before? And if anybody has any questions for me or Dave before we hang up, it's like a FaceTime call.
Yeah, right.
Hang up the phone.
I do want to address Archie's here. Divorce fire from EMS, tie state EMS to hospital. And so, basically, if you look across the country, there's about a third that are tied to hospitals, a third that are tied to fire, a third that are tied to county or municipal parish-based. There's not one right answer. There's a lot of great fire-based EMS agencies. When you take a look at it, a lot of people look at the fireside funding, which is typically tax-based, and we look at this. That's part of what this whole treat in place is looking at, is like funding for what we need to do. Everybody, the days of us billing only for that transport, NAEMT has a position paper now that you can find under advocacy and our positions, that there needs to be an investment, especially when we talk about essential services. There needs to be an investment for readiness. We keep high unit hour utilization on the ambulance side in comparison to the fire side. Fire side is trying to keep that down. Community risk reduction. Don't build fires. Don't do all this stuff, right? So their unit hour utilization is down because they get that tax subsidy where we do not. So we keep unit hour utilization up. And what that means is I want my ambulances going, from a business standpoint, I want my ambulances going as close to 100% of the time as possible. Go from call to call, bring that money in, because if you're sitting there, you're not making any money. And if we looked at funding us differently, funding us from treat in place, funding us for transport, having a subsidy out there for readiness, then we can say, hey, we can give you some downtime. I can rotate you back through and say, hey, you had a tragic call. Come out of the system for 15 minutes, decompress, get you a drink, do this stuff, and then go the opposite side. If you've got good management practices, it doesn't matter whether you're in the fire or the hospital or the municipal based. You're going to have a good outcome. It's just how you take a look at it. So,
and my own opinion on that comment is that, I don't necessarily think that fire and EMS have a lot to do with each other than they are all in the emergency services space. But I think for a lot of people too, it comes down to a monetary reason why they're together, and it's they would have one or the other if they didn't have both together. In a lot of those circumstances, a lot of it's out of necessity, I guess, is what. And if that's the way it has to be, so that people can get the services they need, and that's just kind of the way it has to be.
Yeah, and that's the way I look at it. All it takes is one strong individual to put a good plan together and show how something different will actually work. When you take a look at this, there's a lot of things that we have redundant services. When we have a joint service like fire and EMS together, we don't have two directors in that case. We have a lower level manager for each of them. You have one lead. So that takes X amount of money out of the budget that can be used elsewhere. There's a lot of behind the scenes, the nuts and bolts that not a lot of people like to not a lot of practitioners like to look at unless they're going to that management side. I'm I see a couple of additional comments. Like, we have a lot of good practitioners in all three of those services, whether it's fire-based, hospital-based, or municipal-based. And the more we bring up each and every one of us, the better off we're going to be. So
Yeah. So Bree had a question. She says, do you have the ability to treat and leave at home at all, or is it all in the works? So there are a lot of services out here that are doing like community-based paramedicine, and they have some type of system in place, but usually those patients are like pre-registered through like a community service. It's not like you call 911 and somebody can treat you or take you to the hospital. It's kind of all in the works right now. We're trying to get funding from Medicare, approval for funding from Medicare and Medicaid to reimburse us. That way we can be billed for the services that we provide. So it's mostly in the works right now.
So like you were saying, like we are currently doing it. Like, I use a diabetic patient a lot. The only difference is they currently sign a refusal, which means they're not being taken to the hospital with us. They terminate everything because they are of sound mind and body once they come back around and they have that decision. And what happens is we do all that with no money versus being funded for that. So
right. Well, I think that's all of the questions we had in the queue. Dave, was great having you as always like really insightful, getting your perspective on things. I enjoy our lives together for sure. And we definitely need to keep talking about this to get this bill. As there's more developments, maybe we can start talking more and more about it.
Yeah, we're going to, one of the key things is that the closer we can get to 435 congressmen, and as close as we can get to 100 senators once the Senate companion bill comes out, the closer we can get to having all of those sign on as co-sponsors, the closer it comes to passing. I will tell you, this Congress has got a lot of bills in front of them that's going to change the way EMS is viewed, as the way it's operated. So I think we're going to have a lot of conversations about this this year, which is going to be phenomenal. I think we'll be doing some more of these this year.
Yeah, that sounds great, Dave. Well, you have a great night. Well, stay safe out there, and thanks for hanging out with us, guys.
Don't forget to follow me if you don't get a chance. Go to Handoff Medic, and you'll see us together more.
1000%. Y'all, please go follow Dave. I'm sorry, I forgot to give you a shout out before we headed out, but I meant to say that.
It's all good. I know you do.
Okay.
We've talked a lot.
All right. Well, you have a good night, Dave.
All right. Take it easy. See you.